It's less than 25. A lot of literature support that. It is shock. So for example, if you got that little Asian lady that comes and have a pressure over 90/40, that's 50 of pulse pressure. Not worried about that. A lot of people will say, oh my gosh, she's hypertensive. No, she's not. She's probably have a map of 65, 70, and she has a pulse pressure of 50. I'm not concerned about her, unless she says she feels dizzy and everything. Yeah, no, sure, I may pay attention to it, especially if she's tachycardic. But otherwise, I'm not concerned about it. But the person that has a blood pressure of 100/80, which a lot of people wouldn't be worried about, I am worried about them because they have a pulse pressure of 20. But yet, you see those numbers, they can make difference. Or 110/90. That would seem like a normal blood pressure, but it's not. About 110 over, yeah, it's 30. So it's on the borderline of this. So if I have a map of 60 with 110/90, that means this patient is probably closer to a shock than the patient that has 90/40. So those two numbers are better assessment of your fluids. And be careful about the fluids you're going to use. You don't want to give 2 liters, pretty much maximum that you want to give. Unless you're in septics, and we'll talk a little bit more about that. But in sepsis, it's different because you want to fill out the tank before you can put other stuff on it, and something they'll be very dehydrated because they'll use DKAs will be the same thing. But also, what fluid are we using? This is the other thing too. I'll see a lot of people giving, and don't forget that the salines that you're giving is acidotic. Yes, I'll repeat this so you guys know. The saline that we give are acidotic. The reason? If you look on the component of a saline, it says 144 of Na and 144 of chloride. So 144 of sodium and 144 of chloride. What happened with the body is that when we have too much chloride in our body, it goes to our kidneys. And the kidney says, whoa, I have too much chloride, which is negative, so I have to clear out some stuff. How do I clear out some stuff? I'm going to clear out something else that is negative. What else is negative in our body that goes to our kidney? Add CO3. Yes, bicarb. If I get a red out of bicarbs, what's going to happen? I'm going to stay with H plus in my body. What is HH? Is acidosis. So what I'm creating is what we call a hypercholoremic acidosis, or another term, a metabolic acidosis not with a normal anion gap. Meaning that my anion gap won't be different, but I am still in acidosis. So I can create an acidosis by giving too much saline with it. And sometimes you'll see it, for example, in the CO2 components of some patient. They'll go, actually I saw it one time, not so long ago. The patient had a chloride of, a CO2 of 16. We give 2 liters of saline, which we shouldn't have given. And the the CO2 went down to 11. And like, oh wow, how come he's acidotic? Well, we give 2 liters that we're not supposed to. So for example, DKA, saline is isotonic. If somebody comes and he's dehydrated because of dehydration in their cells, which DKA most likely are, what they need is hypotonic solution, not isotonic solution, because we need to rehydrate their cells, not their isotonic, their vessels. So not into their vessels. We need to replenish their isotonic. So the fluid you give also is important. And in major trauma, preload will be better with blood, not fluids. So anyway, that was just a note on it. Vessels, which one can we use on that? Well, that's where vasopressors comes from. So, Levophed, Norepi, or Epi. But Epi will work a little bit also on this one. So we'll keep Epi kind of on this boat, but for the vessels and the afterload, basically what you want is either the alpha. So in your catecholamines, you have different receptors. You have alpha, beta, and dopamines. Your alpha, there's alpha 1, alpha 2, but for the main purpose here, we'll keep as alpha. Beta has beta 1 and beta 2. And you have your dopamine, which we won't talk much because there's not much effects on those ones. So the beta ones is how easy it is to remember is one heart, so beta 1, one heart. So there's more receptors in the heart, and two lungs. So there's sometime in the vessel, so for example, Ventolin. That's why you increase your heart rate, because it's a beta agonist. Sorry, is that it opens your lungs because it activates, but also it activates your heart. So that way you have that bronchial dilatation, but it's two lungs, so beta 2 lungs, but also works on your vessels. So for example, metoprolol, labetalol is more beta 2 blockers, and metoprolol is more beta 1 beta blockers, which works more on the heart. Still will decrease your blood pressure, but labetalol will decrease more your blood pressure, less decrease your heart rate. And this is the reason. The alpha are alpha receptors, so mostly alpha for arteries. So they're mostly on their afterload. So what's the afterload? Basically is how much pressure your heart has to go against after your heart, which is your SVR, systemic vascular resistance. So basically how much resistance there is after that. So that's why, for example, norepi, this is what's going to happen. So basically it's how big is your funnel. So is it constricting vessels? This is where your distributive shock comes. So for example, if you have anaphylactic or if you have sepsis, sometimes we'll use those because their vessels are so big that no matter how much pressure I get, I cannot create enough pressure in it, because they're going too much of a big surface. So what I'm going to do, I'm going to decrease the surface to create enough pressure to create some movements of my blood through my vessels. But it's just a number, so you don't want just to go with the numbers just for the numbers. So that's where the map is really important. When we're talking about the map of 80 to 90, this is for head injuries. Because in head injuries, we have also the a formula, and it's MAP minus ICP, and it's for the I'm blank here, but basically for the perfusion of the brain. And this is where it's important, because that number over here, you want to keep it between 60 and 100. So if I have an ICP of 20, which would be a massive ICP, and a lot of time we cannot measure it in the settings that we have. Well, if I keep a map of 80, I don't go below 60. If I have a map of 10, I'm still between the 60 and 100. So even if I have an extreme high ICP, by keeping my map to 80, I still keep a good perfusion to my brain. So that's why if you don't have anything to measure the pressure in your heart, in your brain, by keeping a map of 80, you're keeping a good perfusion to your brain just by this concept over here. So that's where we're going to use sometimes some vessel constrictor, which is your vasopressor. A little note: dobutamine versus dopamine, versus norepi. Dopamine is an easy one to do because it's a bag, we flag in, and people will say there's not a lot of extravascular. If it goes extravascular, if you miss your IV or whatever, it's safer and everything. It is true. The problem with dopamine, though, is be careful, because if you are depleted, so for example, if I've been sick for 5 days and I depleted all my natural epi and norepi, or in some case of some overdose, dopamine, how it works is that it goes and activates some hormones that will stimulate the creation, well, not the creation, but sorry, the stimulation of norepi. So it's indirectly creating norepi, and this is how I increase my blood pressure and things like that. But if I'm depleted of norepi, or if some overdose block these things, I will not create that norepi. So I can have a lot of dopamine playing with it and going high up, and still not having the effects on my blood pressure because I'm not creating any dopamine. So very important that when you use dopamine, to be aware of this, because sometimes it may not work, especially with patient that's been sick for a long period of time or that are overdose. I wouldn't jump for the dopamine. I would go more for the norepi right away, because norepi is basically the synthetic form of what we carry normally in our body. Then the contractility, it's the pump himself, and this is the inotropes. So vasopressors means that it plays on the vessels. That will be more like norepi, dopamine will be there. Epi still will work a little bit on this, but epi is a little bit more a beta 1 adrenergic, so basically will stimulate more the heart and increase the heart rate, and as well as the contractility. It's an inotropes more than a vasopressor. It's still a vasopressor, like it still will constrict your vessels. And epi will be better in anaphylactic shock. That would be the first one I would go for. And also in kids, it's an awesome one for kids because it'll increase their heart rate, and we're talking a little bit about that, about kids and how it increase their heart rate and stuff. So epi will work a little bit more on this one, but as well as dobutamine, and then but that's to increase the pump, and this is more the cardiogenic shock. And cardiogenic shock are a disaster to play with because of this, because it's the pump issue. So if you have a big MI, how much muscle, because if you work too much the muscle, they'll get tired and they'll use too much oxygen and everything. So it's how you're going to play with it. But the problem is that if, for example, I put too much fluid in the contractility issue, it's a pump issue. So now I'm overworking a pump that is already very tired and not working properly. So that's why fluid in this case, not always a good idea. But for example, in inferior MI, it can work because you'll work on the elasticity of your muscle, which is called the Starling laws, where basically you're going to extend your ventricular not contraction, but the tissue enlargement of it, and then you're going to push it by just this mechanics, basically, not the contractility itself, but just by mechanics. So because you stretch the ventricular somehow, it's going to go back. So that's why in some case fluids are, but again, it's to understand first of all the pathology that you're facing with, and then after that, understanding this concept of cardiac output equals stroke volume times heart rate. So the pumps. So now you want to affect the pumps, and that means depending on the medication you're going to need, and it means also, like for example, in refractory shock, in some case, calcium can be also something that you may reach for. Yes, the calcium that we carry on the cardiac carts. If you give that to the patient, they may be able to increase their contractility because you already give, for example, let's say you maximize your preload, you maximize your afterload, because don't forget that if you constrict too much the tank over there, that means the heart will have too much hard time to push all that blood against it because it's so strict. So now I have to increase maybe my pump, and calcium can be a good use over here sometimes. So sometimes doctors will be using calcium to increase the contractility of the pump, to again maximize all those three things, to increase the stroke volume so that my cardiac output, because this is the maximum, this is what we want. We want a good cardiac output. It's not about maximizing so much the stroke volume, but it's how can I maximize my cardiac output? And it's by playing with those three things and the heart rates as well. So for example, if I have someone that is already really tachycardic, so for example, you have someone at 150, 160, and I have a choice between what I'm going to use as my agent, maybe I'll stay away from epi, which I know is a beta 1, which means I will increase my heart rate. But because I increase my heart rate so fast, it won't leave the time for my preload to happen because my heart is going too quick. So that's where I'm going to probably go more for a norepi, which has a little bit less effect on the heart rate. It still has an effect, but a bit less. It has more an effect on the afterload. Will constrict my vessels. A little bit of inotropes, not much, but it will still play a little bit on the contractility, and will give a little bit more time. It won't maximize the time, and as my circulation improves, probably my heart rate will go down, which will increase my preload. So you see how all those things kind of can go into your head when you approach the patient with this stuff. Anyway, I'll leave you on this, and hopefully that was useful, and if you have any questions, don't hesitate to call me.